All right. I think we're kind of hovering around the 50-person mark right now. Maybe a few more people will hop on as we get started, but I think we're safe to go ahead and start the chat and kick things off if you're good with that, Dr. Beam.
Yes.
Awesome. All right. So thanks everybody for joining us tonight. Really excited. We have a great presentation for you. I'm Rachel. I run the marketing and communication side of things. Some of you have probably heard me speak before. This is our debut webinar with Dr. Gloria Beim, and she is our newest surgeon at VSON Alpine, which comprises our clinics in Crested Butte, Gunnison, and Telluride. So for those of you who don't know, VSON, Vail Summit Orthopedics, just merged, partnered with Alpine Orthopedics, which Dr. Beam has been around since, I'm sorry, is it 1994?
Six.
Okay. 1996, sorry, got that. So yes, Dr. Beam founded Alpine Orthopedics in 1996, and she is still the sole owner over there. And she is a wildly accomplished surgeon, and we are very lucky to have her on board, and very excited for her to be doing this intro webinar and kind of give you a little bit of background and talk about ski and snowboard injury prevention, which is an area she particularly shines and is an expert in. So with that said, we will kick things off, and towards the end of the presentation, we're going to do a Q&A portion as usual. So if you're not familiar with how we run that, you can submit your questions via the chat box, or you can submit them via the Q&A box on the bottom of your screen, and we will get to as many as we can in about 20 to 30 minutes, total amount of time for questions towards the end of the presentation. So with that said, Dr. Beam, I'm going to let you take it away.
Thank you. Whoever's on the line here, I'm grateful that you are spending some time with me tonight. I'm excited to share this with you. I didn't make it too gruesome, so there's a couple of crash videos you might want to close your eyes. I'll give you a warning, but otherwise it's not so bad. I've been doing orthopedics in private practice now for over a quarter of a century. I hate to admit I'm that old, but I have a lot of experience in this, and I prefer to see you guys on the hill skiing and snowboarding and having fun rather than in my clinic. So I'm going to try to give you some tips on how to stay out of the clinic. And also I'm going to go over a bunch of different injuries that I see every year again and again, and certain ways that you can prevent it. So I'm just going to jump right in. And at the end, I'm happy to answer questions. I don't know if I can answer everything, but I'll do my best. So I see probably more injuries in snowboarding than skiing. Sorry, snowboarders, but I do. However, when it comes to lower extremity injuries, by far and away, I see it more in the skiers. Snowboarders have more of the upper extremity injuries, and particularly in beginners. If you're just starting out snowboarding, you know, it's a steep learning curve, but quick. However, in those first few days or weeks, injury rate's pretty high. So I'm going to give you some tips to try to avoid getting injured. So in the snowboard injuries, in the upper extremity, by far and away, wrist. I see a lot of wrist injuries, and most of these can be prevented if you wear the wrist guards. I'll talk about that in a little bit. Shoulder dislocations are quite common. Clavicle fractures or collarbone fractures. Arm fractures, particularly in the humerus. And then in the lower extremity, you can still see injuries in the snowboarders, including ankles. I had a big ankle fracture from yesterday in Telluride from a snowboarder. Knee ligament injuries happen, but not nearly as commonly as in the skiers. And then you can get spine injuries and concussions. We're not going to go into those tonight because there's just not enough time. So here's an example. This was in Sochi. This is Sean White, most of you guys know, and he hurt his back on that one. Kind of sad. I think he was going to win gold right there, but it happened. Even in the pros, injuries happen. He injured his back on that one. In skiing, lower extremity, most common, knee injuries in particular, the ACL, which we're going to get into great detail about, MCL, meniscus, tibia fractures, which are in the lower leg, hip fractures. And then in the upper extremity, I see thumb injuries quite a bit. There's a little ligament right here that can tear. It's called a skier's thumb. I'll mention that as well. And then concussions and spine injuries as well. The concussion and the spine injuries are more commonly in the terrain parks, which I like to call the trauma gardens. That's where you really see it. High energy, big air, bad crashes. That's where you see some of the really bad stuff. And trees. Avoid trees, please. They don't move when you hit them. So let's go over just quickly, what is the musculoskeletal system? Because that's what I'm talking about. That's what orthopedics take care of, is the musculoskeletal system. So you have skeleton, you've got the musculature, and then you've got the arteries, veins, and nerves that supply all of those muscles and bones. So the musculoskeletal system provides our form, our upright posture, allow us to move, and it also protects our vital internal organs. So in the skeleton, if you guys were here in an audience, I could quiz you and give you prizes, but darn, I can't do that. Anyways, there's 206 bones in the skeleton. And again, it protects our vital organs. For instance, here, the rib cage protects the heart and the lungs. The pelvis protects a bunch of organs in there. Here, in between the rib cage and the pelvis, not a lot of bony protection. So these elements in the abdomen can be at risk of injury as well. The bones also produce blood cells that we need. Muscles, very important. There's about 630 or so muscles. And then there's soft tissues that connect the muscles to bones. So we've got tendons, which attach the muscle to the bone, and that allows us to move. For instance, this is a biceps muscle. Here's the biceps tendon. It attaches to the radius, which is one of the two bones in the forearm, and it allows us to move our arm, the biceps. And then the triceps straightens the arm the opposite way. Ligaments connect bone to bone. So you've heard of ligament tears, like the ACL, the dreaded ACL, anterior cruciate ligament. It connects a bone to a bone. So this is in the elbow. This is an ulnar collateral ligament. And then the muscles and the bones are supplied by vessels. So blood vessels that bring the blood to the muscle, gives us oxygen and nutrition. And then the veins take away the byproducts and the carbon dioxide. And then these yellow things here are nerves. This is called the brachial plexus. The reason I show you this picture is later on when we talk about shoulder dislocation, you can imagine when a shoulder dislocates where the head comes out of the socket forward like that, it can compress many of these structures and that can cause injury as well. Some of these injuries can be quite dangerous in certain circumstances. Joints form these little capsules that connect a bone to a bone. Again, the ligaments are kind of part of the capsule in many instances. And in the winter sport injuries we're talking about today, the most at-risk joints are the shoulder, the knee, and the hand. So let's talk about some injuries. What's a broken bone? It's the same as a fracture. A lot of people say, no, I didn't fracture my bone, I broke it, or vice versa. Same thing. So it's a broken bone. But with that broken bone, you can also get soft tissue injuries. You can get compartment syndrome, which I'll mention in a few minutes. And then you can get injuries to the nerves and the vessels, like in that picture I just showed you, because they're all kind of in the way. A dislocation is a disruption of the joint. So if the ball comes out of the socket, for instance, of a hip or a shoulder, that's a dislocation. So the bones are no longer in contact. They're out of joint. Ligament and soft tissue injury is the rule, not the exception. And neurovascular injury, the nerves and the vessels, are at risk as well. A subluxation is similar to a dislocation, but it's not a complete disruption of the joint. So for instance, in the shoulder, you got your head, you got the socket, it starts to come out and it comes back in. So it doesn't go all the way out. So that's a subluxation. And then a fracture dislocation, those can be very bad. That's where you get a combination of a dislocation and the bone is broken. So that's a pretty bad injury. Now, significant forces are generally required to cause fracture dislocations. You can get direct blows on the snow, indirect forces, like a tree, twisting forces, and then high energy forces, again, a tree or a wall. Here's an example of some injuries, just to keep you guys interested. So if you can avoid walls, that's one preventative measure, and rails, those can hurt. And then if you just take a little bit too much of a jump and you get out of balance, you can get injured that way too. So try not to do those. I know some of you guys in the audience do it, but be careful. Okay, let's get more specific. A sprain. A sprain is where a joint is twisted or stretched beyond its normal range of motion. And a sprain is where you tear the ligament. The ligament is where you connect bone to bone. So here's a really common injury. I do see it in snowboarding at times, especially if there's the soft shell boots or the hybrid boots. But it's really common in basketball, volleyball, sports like that where you're pivoting. But you can see here that the lateral ligaments here are torn. You don't usually see a deformity unless it completely dislocates. So you stretch it, you tear the ligament, and then it kind of pops back where it belongs. So on the outside, it doesn't look deformed at all. A strain is an injury to a muscle or a tendon. So this is the hamstring in the back of your thigh. And here is what we call the muscular tendinous junction. And you can see you can get a tear in the muscle tissue. And that's called a strain. And those hurt. How do you treat strains and sprains? Well, you've heard of RICE, I'm sure. Rest, ice, compression, elevation. That's a great treatment to start with. You can also take some anti-inflammatory medicines like ibuprofen or Aleve, if it doesn't bother your stomach, of course. I also like arnica, which is a natural anti-inflammatory. You can either take it by mouth or you can even take cream and rub it around the injured area. But when do you see the doctor? Well, if you have a tremendous amount of swelling, if you have significant pain with weight bearing, if the ankle does look deformed, if you have numbness or tingling in your foot or toes, you really should see a medical professional to see if there's a fracture. Is there a significant enough sprain that you need more treatment than just RICE? I love physical therapy. I'm a big physical therapy advocate. They make me look good. They make my patients better much more quickly than if my patients didn't go to PT. PT is essential in ankle sprains and strains and other joint sprains and strains as well. And the reason is, particularly in the ankle, if you don't do PT, if you just do RICE and kind of limp around for a couple of weeks and get back into your sport, you have a 10-fold increased risk of re-injury. Whereas if you go to PT, you get rid of the inflammation, you get your range of motion back, you do a strengthening program, and then you do a proprioception program. Proprioception is balance training. And if you do all of that, again, your risk of re-injury to that joint is 10-fold less. So I really like PT. Acupuncture is also excellent. When I first came out of medical school, we were kind of taught that it was kind of nonsense, it didn't really do anything, but that's not true. In the past 10 years, particularly, there's been a tremendous amount of studies that have shown that acupuncture is incredibly effective to help with all kinds of musculoskeletal injuries. It can increase blood supply, which is great because it can help reduce inflammation. It can help healing. There's even a study that showed that acupuncture can activate stem cell formation, which is incredible. Stem cells can help tissues heal. That doesn't mean I want you to go out and get stem cells and everything. That's another topic altogether. But if you can stimulate your own stem cells in your body, that's an advantage. It can also raise your pain threshold so you don't hurt as much. It's wonderful. So I love acupuncture, not as a replacement for therapy, but as an adjunct. Now, sometimes you need advanced imaging. So if you came into the office, normally you'll get an X-ray, but sometimes you'll need an MRI or a CT scan as well, based on the injury pattern. How do you prevent injuries? We're going to go over a lot of specific injuries, but just kind of overall, how do we prevent injuries? Number one thing I tell people is preseason conditioning. So October, maybe even September, October, November at the latest, you want to get into a ski conditioning course, or if you can get one online, that's fine too. But you want to condition and get ready for skiing. Once you're conditioned and you're ready to get on the slopes, and this is for snowboarders too, you want to warm up, and then you want to stretch. Stretching is very important to help prevent injury. Then you want to cool down. In between your skiing and snowboard sessions, yoga is a great way to stay flexible and keep your body in great shape. And then your equipment's important to be tuned and properly fitted. So if you don't have it fitted properly, go see a professional, make sure you do, because that's a huge way to reduce injury on the mountain. You want a safe environment. So if you're on the hill, yeah, you got the ribbon of death, there's not much snow yet, and there's a bazillion people, maybe don't ski that day. I know I don't. But if you can pick your days, when the conditions are good, they're safer, it's better. And then make smart choices. Going into a tree run, especially if you're not that confident with your skiing and snowboarding, not a good idea. Like I said, trees don't move when you hit them, and that's where the real serious injuries can occur. But even if you're a professional, I've seen plenty of very elite athletes and coaches break femurs and break tibias in the trees. So be careful, make smart choices. So now we're going to get into some more specific injuries. Clavicle fractures, very common in snowboarding. They're going to have pain in the shoulder. They're not going to want to move at all. So if you try to move them like this or move yourself like that, it's going to hurt. So this is the collarbone. You can see here that there's a bump. That's pretty typical. And on this x-ray, you can see that there's a big displacement between the two ends of the bones. So that's a clavicle fracture. This is a good mechanism. You fall right onto your shoulder, right onto the front or top of your shoulder. So how do you treat them? Well, this right here, this is a bad one. This is called a Z pattern. Looks like a Z. This is comminuted, which means there's lots of pieces. This is the one that's going to end up getting a plate or some type of surgical intervention. Before 2008. In 2008, there was this landmark article that said if you have more than 2 centimeters of shortening in the clavicle, you should fix them all. Before that, we were always taught for decades, don't ever fix a clavicle. You don't need to, unless it's open, sticking out of the skin. That's not true. If you have more than 2 centimeters of displacement, it can really affect the biomechanics of your shoulder, particularly if it's your dominant side, and if you're an athlete, particularly overhead athlete, climber, aggressive skier, etc. So when they're that bad, we do fix them, and it's great because people can start moving right away. Their recovery is more quick, and it's way less painful, because until these bones start solidifying and getting sticky, every breath, every cough, every sneeze really hurts badly. So it's a great treatment. But if it's minimally displaced, I don't. I put them in a sling and people heal. So mechanism again, fall onto the front of, or top of your shoulder. Super common in biking too. So don't do this if you want to not get hurt. So Mom, if you're on this webinar and watching, please don't do this, okay? Kind of crazy. So that's how you're going to slam into a rock and get hurt. Anyways, cool video. Okay, so now we're going to talk about shoulder dislocations. Very common in snowboarding. Again, I'm not picking on you snowboarders. I'm just being honest. Sometimes you can dislocate where it comes out and it pops back in by the time you see the doctor or the healthcare professional. So it's important that you tell them, I think my shoulder came out. I felt a pop, and it just didn't feel right. So that's important for the practitioner to know if you go see somebody. If the dislocation doesn't come back in, that can be a very serious problem because it can affect those nerves and vessels that I showed you earlier. So it's very important that you be careful. Stand by 1 second. Stand by. I'm sorry, I just got out of surgery. Tell her that that's what I told her we would be doing. Okay, I don't know why that's. No, not necessary. No, thank you. Sorry, guys. No worries. Okay, so yes, a dislocation that doesn't come back in is a serious problem because of nerves in the vessels. So here's an example of different dislocations. So here's normal on the left. In the middle, it comes out the front. That's about 90% of dislocations that we see, particularly traumatic dislocations. It comes out the front of the shoulder. The back, if it goes out back, that's more common in people with seizure disorders because the muscles in the back are so powerful, they pull the head out the back if the patient's having a seizure. So by far and away, going out the front is the most common. So how do we have shoulder stability? Well, if you look at a hip, Look at this. It's a big ball and socket. Bony wise, it's incredibly stable. But on the shoulder, it's like a big golf ball and a golf tee. Flat tee, which is the glenoid or the socket. Big ball, the golf ball, which is the humeral head. Here's an x-ray of that. So you can see it's pretty flat. So there's not a lot of bony stability. So how do we not dislocate all of the time? Well, there's two types of stability in the shoulder. One is static stability, and that's with the labrum. Some of you listening out there may know about this, may have had labral repairs or labral tears. This is the labrum. It lines the joint, and you can get tears in the front and in the back. But without the tears, if you have an intact labrum, it does give you some form of stability. Plus, there's this capsule that surrounds the whole joint. Remember, we talked about capsules in joints, and it gives you this static stability that's there all the time. The muscles, the rotator cuff muscles that some of you, I'm sure, have injured in the past, they give you dynamic stability. So when the muscles are contracting, it gives you stability. When they're resting, they don't. So if you have a big labral tear, your shoulder isn't coming out all the time because your rotator cuff's working. But if your rotator cuff doesn't work for a second, it can pop out. For instance, somebody can be asleep in bed who maybe dislocated multiple times and have not gotten it fixed. They're pretty unstable. They could be asleep, roll over in bed, and their shoulder pops out in their sleep because their muscles aren't firing properly. Or I've had some people where they go off a jump and they're kind of doing this to get their balance, and they pop out because the muscle isn't firing properly to keep it in. So it's very important that you have good static stability with the labrum and good dynamic stability with the muscles. How do you treat a shoulder dislocation? Well, if you're all by yourself, you got to try to get it in. This guy here is doing a maneuver that can help. So you bend your leg, you lock your fingers, and then you kind of extend your leg, and sometimes it'll pop back in. This is how many practitioners do it. They have a traction, counter traction. So one person's pulling a sheet this way, and then the practitioner is pulling on the shoulder to try to pop back in. So if you can avoid it, you're better off. If you do dislocate it, can't get it in, you see a practitioner, they're going to do some x-rays, see if there's any broken bones as well, and they're going to protect your nerves and circulation by getting that in right away. After that, physical therapy is important. Often we'll do advanced imaging like an MRI or an MRI arthrogram where you put contrast in so you can see the structures better. Age can predict pathology. So if I have somebody under the age of 20, there is almost 100% chance of dislocating again, unfortunately. So a lot of these younger people actually do need surgery to fix this. If you're over 40, you don't re-dislocate quite as often, but in the people over 40 are more common to tear their rotator cuff tendons, and that can require surgery as well. So it's really important that you see a good orthopedist to evaluate this and decide if you have any of these problems. So if you have significant tears, or if you have recurrence, it dislocates again and again, you got to fix it, because every time it dislocates, you can damage the cartilage, which is the white stuff on the chicken bone in the joint. You can damage the labrum further, you can damage the rotator cuff, you can even fracture. So it's important to get those fixed if it's a recurrent issue. Now, prevention. I don't know if the younger audience recognizes this guy. This is Henry Houdini, and he used to get out of these straight jackets and chains and all this other stuff. And his secret was he could voluntarily dislocate both of his shoulders. So he'd be in a straight jacket, and when they put the straight jacket on, he would be reduced. And then while he's in the straight jacket, he would secretly dislocate both shoulders. So then he had more room to move to get out of the straight jacket, and then he'd pop him back in. I don't recommend that to anybody, but that's what he did, and it worked for him. But don't do it. Anyways, rotator cuff strengthening is super important to increase that dynamic stability to help with a labral tear or static stability deficit. There's some braces like this where I'll put these on some of my football players if they want to finish out the season before they get fixed. That can help reduce your risk of redislocation. But again, if there's recurrent dislocation, you should really get it fixed. Now, if you're like Henry Houdini and you have really loose ligaments to allow you to dislocate at whim, you don't usually want to operate on those people, because their ligaments might be super, super loose, or they may have a genetic deal. It's called Ehlers-Danlos. So it's genetic loose ligaments. And these people can dislocate lots of different joints. You know, the people in the circus or Cirque du Soleil that can just get in a box, they get all pretzeled up. These people usually have Ehlers-Danlos. You don't want to operate on them if you can help it, because what happens is if you tighten their ligaments, they just stretch out again. So I try to avoid surgery on people like that. All right, next injury, acromioclavicular joint or AC joint, that's here on the top. If you land on your shoulder on the top, you can tear these ligaments here. And if you tear these ligaments, sometimes you can have a deformity like this. Super common in snowboarders, sorry to pick on you guys again. Also hockey and biking. In the summer, we get a lot of AC injuries. This is a mechanism. So I'm the team doc for wheelchair basketball, and they just won a gold medal in Tokyo again. They're the best. Anyways, this is a perfect mechanism right here, landing on the shoulder like that. These guys get hurt all the time. They're so tough. They never complain, and they just get right back in their chairs and play. Best athletes I've ever seen, by the way. So AC dislocation, you've got these ligaments. You've got what's called the acromioclavicular ligament. You've got these two ligaments here called the corticoclavicular ligaments. And depending on the severity of the tears, decides what kind of treatment. So for most people, type 1, which is a mild sprain, type 2, which is a tear here and a mild sprain there, and type 3, where you tear all three, most of these we treat without surgery. I tell the patients, you can have a bump, but so what? You're going to do fine. However, if you're an elite athlete overhead, so you're an elite pitcher, I don't mean you play softball on the weekends, I mean elite pitcher, college pitcher, or you play professionally, the threes you probably want to fix. Then there's type 4, 5, and 6. That's where you get all these ligaments torn, but the clavicle gets stuck in the muscle. You need to fix those as well, no matter what kind of athlete you are. So depending on the severity, we'll decide on whether surgery is indicated. Next, humorous fracture. It's not very funny, huh? So in the arm, you can break right there. Now, believe it or not, this patient we treated with just a splint and they healed. This bone is very forgiving. You don't have to have it perfectly aligned like many other bones in our body to do well. So we usually splint these and they do quite well. Elbows, mom, I know my mom's on there, so I'm just gonna keep bugging her. I dislocated my elbow when I was a kid. She'll never forget it. I won't either. It was terribly painful. I was doing gymnastics in the living room and I had a misstep. Anyways, these are very difficult to reduce on your own. You usually need a doctor to do it. And until it's in, it hurts like heck. It really does. Extremely painful. You can also get a fracture with these dislocations as well. So you need to get in with an orthopedist pretty quickly, or any medical provider that's comfortable taking care of these. But once you get them in, they're pretty stable. You want to do early motion and PT. They rarely need surgery, believe it or not, but you got to get that motion early because elbows stiffen up really, really quickly. So you got to get early motion. If the elbow is so unstable that you can't do early motion, that's when we take you to the operating room to stabilize it so you can do early motion. Elbow fractures, these can occur when you fall in an outstretched hand, which is, again, sorry, snowboarders, really common in snowboarding. Here is the radial head and the radial neck. And these fractures are not uncommon when you fall in the outstretched hand. If they're completely non-displaced and they're stable, so we can move your elbow right away, no surgery necessary. But if they're causing locking or they're displacing, you have to fix them, and you have to fix them soon to get that elbow moving. So again, on an outstretched hand, you can either injure the wrist, we'll talk about that in a minute, or the bones in the elbow, excuse me. And then if you land on your elbow, in certain ways, landing on your hand as well is when you can dislocate the elbow. I did mine in gymnastics, landing my hand with a funny twist. It was no fun. So here's some more elbow fractures. Here is an olecranon fracture. This is when you kind of land right on the point of your elbow, and your triceps, which extends the elbow, is attached to that bone right here. So if you break the bone, the triceps pulls it right out of place. Have to fix those. So what we usually do is put a plate on it like this. Start early motion again. Extremely painful until it's fixed. Again, if you ask me, how do I prevent these? Well, don't hit trees, don't take big air, and don't go so fast on the skis and snowboard that if you crash, you're going to break something. But that's it. There's no exercise to prevent fractures and dislocations. It's just traumatic. Forearm fractures, super common. I see them in all age groups. And when they're more closer to the wrist, you can get something called a dinner fork deformity. I see these in kids a lot as well. So it looks like a dinner fork because the bone is broken and it has this dinner fork appearance. You got to get those to the orthopedist without question. With younger people, we can usually put them back and put them in a splint and then ultimately a cast when the swelling goes away. Usually both the radius and the ulna break. But in the adults, if you have these both bones broken, you gotta fix them. They're not as, you don't have as much room for error as in the kids. The kids have open growth plates. They can remodel their bones, but the adults can't. So if you land hard enough on an outstretched hand, or if you hit a tree like that, you can get this, and then you need the plates. So wrist fractures. Sorry, snowboarders, very common. Falling outstretched hand. I've even seen professionals, they do this huge, I was at the X Games once in I can't mention names, it's HIPAA, but there is this amazing guy and he did this amazing run and he gets to the bottom and he's high-fiving his buddies and then all of a sudden he just slipped and he put his hand back, which is typical reaction, and he broke his wrist. So that's what can happen. Now, wrist guards work, okay? There was a study done a little while ago, and they studied 100,000, there's 100,000 wrist fractures from snowboarders annually. This was already 10 years ago, so there's probably more now. But 25% of snowboard injuries are in the wrist. And they showed that if you use wrist guards, the risk is less than, it's tenfold less than if you don't have wrist guards. Unfortunately, most snowboarders don't wear wrist guards. It's really sad. They really should. I know it's not cool, but there's a solution. There's these, and I don't work for Decine, but I recommend these Decine gloves. They're like, I don't know, $40. And they have, they have built-in wrist guards. They're unbelievable. So your friends won't know you're wearing them. The wrist guards are in there. It reduces your risk of wrist fracture significantly. This is my 26th winter season here in Crested Butte. And honestly, I cannot recall one, a long time ago, I had a little scaphoid fracture in a patient that was wearing wrist guards. Other than that, all of my wrist fractures have been without wrist guards. So I highly recommend them. And it can reduce risk significantly. Now, there was an article in Snowboard magazine in the late 90s that said, don't wear wrist guards because you're going to get worse injuries up here. Nonsense. They got that information from an article, a poorly designed article done on rollerbladers where they had only 6 rollerbladers. And they said that there's an increased risk of injuring other things. So don't wear wrist guards. Horrible study. And I don't know how it got into the Snowboard magazine, but trust me, wrist guards can reduce injury significantly. Now, I'm going to pick on the skiers. Okay, enough snowboarders. Sorry, picking on you guys. When you wear poles and you fall, the ski pole can push your thumb out that way. And if it does that, it can tear a ligament right here. This is called the ulnar collateral ligament of the thumb. I see these all the time. They often need surgery too. So it can be a devastating injury. So one way is if you have, the poles wrapped around your wrist with the straps. Second, you think you're going to fall, drop the pole. You're not going to hurt anybody because it's still attached. But if you fall with the pole like that, there's a high risk of injury. There's 3 different types. Grade 1 is just a little mild sprain of that ligament. Remember, the ligaments attach bone to bone. Just needs a splint for 2 to 4 weeks. Grade 2 is a complete tear, but the ligament's sitting where it belongs. So you can put those in a little, I call them a bikini cast, where you have full motion of your wrist, your fingers, even the tip of your thumb. It's very low profile. And you wear that for about a month, and then you wear a splint to protect yourself. And you can go right back skiing as long as you're protected with a cast or the proper splint. And then the type 3 is where the ligament actually moves out of the way and it can't go back where it belongs. And those have to be operated on. Here's another mechanism of injury as we're going to start going into lower extremity now. Boom. Don't do that. That's silly. Okay, so I'm going to speed it up because I'm running out of time. Dislocation of the hip. This is high energy stuff. I'm not going to spend a lot of time on it. The only way to prevent this is don't run into trees and do too high energy stuff. That's it. If you're going to do that stuff, this can happen. This is unusual. This happened in the X Games when it was in Crested Butte. I think it was in 97 or 98 when Evel Knievel was here. He was my hero. Anyways, this guy was on a snow bike racing downhill, crashed horribly and dislocated both hips, one out the front and one out the back, which was incredible. Femur fractures, again, the only prevention is don't run into trees, don't dig high energy stuff. If not, you're at risk. Here's a femoral shaft fracture. This is the strongest bone in the body. So it takes a lot of energy to break these. Just avoid trees and be careful in that trauma garden. So real quick, I'm going to go over knees because I know everybody loves this subject and I could do a whole other webinar on this. But real quick, the knee anatomy, you've got multiple ligaments. They're not all shown here, but these are the major ones. You got the ACL in the front, anterior cruciate, the PCL in the back behind it. And it's called cruciate because they cross. So you got the anterior cruciate, posterior cruciate, and they give you a lot of stability in the center of the joint. And then you have the MCL, the medial collateral ligament, the lateral collateral ligament. And fortunately, LCL injuries are pretty rare in skiing. MCLs are the most common in the knees. They happen a lot. I'll show you how that happens in a moment. And then you have the meniscus, which is the shock absorber of the joint. Super important structure. Here they are, the meniscus, in between the femur and the tibia, or the thigh bone and the leg bone. So ACL tears, everybody's heard about them in football players and skiers and just about any pivoting sport you can think of. Snowboarders too, not as quite as often as skiers, but they do happen. Major stabilizer, when you tear them, you're gonna usually, but not always, hear or feel a pop, and you're gonna swell within an hour or two. Sometimes you'll feel nauseous. You kind of fall in the snow and you kind of feel sick, like, oh, something's really wrong. And that's a good sign that you may have torn your ACL. If you want to go back to pivoting sports and continue your athletics, it's a very good idea to have it reconstructed. You can't repair it. It doesn't usually heal. That's rare, where you can get one where you can actually just reattach it. Usually you have to reconstruct it with a graft. But it's a big injury and you're out for at least 8 months from pivoting sports. So it's a big deal. And here's an example of an intact ACL on the left, and then this is how it can tear. So mechanism, attempting to get up while you're still moving after a ski fall, attempting a recovery from an off balance position, particularly like this guy, he's off balance and he's going to try to get up, he's likely going to pop that ACL, and attempting to sit down after losing control. So these are big mechanisms of ACL tears, and I'm going to show you hopefully some tricks to avoid that. So this is called the phantom foot. There is an orthopedic, good friend of mine in Vermont years ago. He studied hundreds and hundreds of videos of people who tore their ACLs. And he came up with this kind of phantom foot profile that if you have all 6 of these elements, you will tear your ACL, okay? And then another way is this boot top. If you're taking a jump and you land on the ski tail, that's another mechanism of injury. But let's focus on this one because this is super common. So if you're falling and you get your hips below your knees, you're off balance to the rear, your uphill arm is back, your weight is mostly on the downhill ski tail, your uphill ski is unweighted, and your upper body is facing the downhill ski, you're probably going to pop your ACL. Okay, that's the phantom foot profile. So knowing all of that, if you can do some immediate recovery measures, you might avoid the ACL tear. One quick, easy one is get your hands together. So if your uphill arm is back, and that's going to make you rotate and increase that torque and that force on that ski to tear your ACL, one way is to try to get your hands back together. Another way is to try to get your feet back together. So if your uphill ski is unweighted and your downhill ski tail is getting all the energy, if you can balance those out, you're likely not going to tear your ACL. So those are the two easiest ways to try to bail out of this. So here again, tear of the ACL, you've got a rotation moment. This is on the left what the ACL looks like through an arthroscopic view. This is normal. And then this is torn. Sometimes they just poof. They can just completely disrupt. And other times they'll just kind of peel off the wall. And then by the time we get in there surgically, they can sometimes scar to the PCL behind it. But that doesn't give you rotational stability. It's not good enough. You've got to get tissue in the anatomic position where it came from to give yourself a stable knee. So ACL reconstruction, again, you rarely can repair these. But what we do is we take a graft, and that's another discussion. If we get enough feedback, I'm happy to do just a talk on ACL surgery if you like in the future. But you take a graft from somewhere else. Particularly if you're a younger person, you want to use your own tissue. If you're way older, yeah, allograft, cadaver graft works fine. But we take the tissue and we put it in the anatomic position where it came from, so that it's in the right position to give you the best stability. It's about an 8-month recovery minimum. Some people cheat and go back sooner in sports and they can re-injure it. And that's kind of a drag. It takes about 8 months minimum for those soft tissue to really mature into the bony tunnels that you put them in. Despite your best efforts at ACL surgery and recovery, about 50% of patients still get arthritis within 10 years after an ACL tear, which can be devastating for instance, a 16-year-old kid who tears their ACL. It really is a big injury. If you do ski conditioning, good strength, particularly good hamstring and quad balance, good hip strength, the hip flexors and the hip abductors, good hamstring flexibility, all these elements can reduce your risk of ACL injury and other knee injury for that matter. Now with the MCL, the medial collateral ligament, which are more common, they usually heal on their own. They're outside generally of the capsule. They're outside of that synovial fluid environment of the joint, and they usually heal quite well. I don't often have to fix these surgically. Almost all of them heal on their own. And then some people say, well, what if I wear an ACL brace or an MCL brace? The studies have not shown that those really prevent injury. In fact, I've seen multiple ACL tears in people, and MCLs too, in people wearing braces. Now, they might reduce your MCL risk a little bit. Some studies do suggest that, but they definitely do not reduce risk of ACL tears, the braces. So for the MCLs, this is the valgus stress. We call it valgus, where the knee comes in and then the ligament gets stretched or torn on the inside. We usually treat those with PT and bracing. Again, rarely need surgery for those. And then the meniscus tear, it's a shock absorber of the joint. It's so important to preserve those, because if you don't have those, you end up with bone-on-bone arthritis. No brace prevents this either. It's just if you get, deep squatted position, hyperflex with a twist, they can tear. And as you get older, the meniscus gets weaker and easier to tear. There's no good replacement. So you want to try to preserve those for sure. The way we treat those, the outside of the meniscus, the peripheral, is where there's the blood supply. So if there's peripheral tears out here, we can put stitches in and repair them, which is great, because then you don't lose any meniscal tissue. However, if they're in the central portion where there's no blood supply, we call it the white zone, they don't heal. For instance, this one is in the white zone. We just trim out the torn portion and try to preserve as much meniscus as we can. A tear like this will likely cause locking or catching symptoms, and you want to get those taken care of sooner than later, because every time you lock or catch, that tear can potentially propagate and get bigger. Fractures, I'm going to bust through these. Again, no real prevention for this except making smart choices. But you can fracture the femur, tibia, the fibula, and the kneecap. Those are all the bones around the knee that can be fractured. This is a bad fracture. This is called a tibial plexus fracture. I see a lot of these every ski season, more common in the skiers and the snowboarders. But this is the top of the tibia. This thing is just destroyed and it has to be operated on. If it's non-displaced, no. But when there's displacement, particularly like this, in a ton of pieces, you got to fix them. This one was so bad. Here's the meniscus sitting on top, and this is a plateau, and it's angled 90 degrees. So we had to get that back up, fill it up with a bunch of bone graft, and then put plates on it. Hang on a second. I don't know why this thing had just popped up here. Okay. Tibia fractures. Oh my gosh. Hang on. Why is it doing this? Sorry, guys. I don't know how to turn this off. Okay. Oh, I'm just gonna push it over here. There. So the tibia, big bone in the leg. Fibula is the smaller bone. This is called a boot top fracture. We see these all the time in skiing. We see tibia fractures in snowboarders as well when they hit trees and stuff. This has to be fixed. We usually put a rod down like this. Patients are up, moving their knee and ankle pretty much right away, and they can weight bear pretty soon. A fracture like this that goes into the ankle joint often needs plate and screws, and that takes longer to recover from. And this is one of my not so bright patients that I told him don't ski till he's healed, but about 3 weeks after his rod, he hit the slopes again, and he bent his rod, and it was very difficult to get it straightened out and revised. So don't go back on the slopes till your doctor tells you to. Ankle sprain, we alluded to it earlier. The lateral ligaments can be torn. Super common in basketball and volleyball as well. Treatment, like I mentioned earlier, PT, bracing, and then this proprioception balance training is so important to reduce your risk of re-injury. This is a snowboarder's ankle. Sorry, I'm back to you, snowboarders. It's a little fracture off the talus bone, which is this bone here in the ankle joint. It's commonly missed. So it's important that if you were told, yeah, you have an ankle sprain, but things just aren't seeming right, sometimes you need to get even a CAT scan, a CT scan, to make the diagnosis of this fracture. And if this little fragment's big enough, you need to have surgery for that. And then finally, ankle fracture dislocation. If you're squeamish, don't look at the screen. But that's for the obvious deformity. This is more than just a sprain. So this person broke his fibula and he dislocated the joint completely, and that needs emergent surgery, and people do fine. Okay, so we're going to stop here. This is Tyler Walker. This was in Sochi in the Paralympics. Amazing, brave guy, and he's an amazing sit skier, and he has an injury. If you're squeamish, please don't look. This is a horrible crash. And the reason I'm showing it to you is I want to show you how these Paralympians are so incredibly brave, and with all the, I don't call them disabilities, I call them abilities that they have. They do the most amazing sports. Horrible, but there he is. He came back 4 years later, Pyeongchang, got a silver medal in the same competition, and he's incredible, incredibly brave. So that's it. I am ready to take your questions.
All right, thanks, Dr. Beam. For those of you who are still on, we would love to host a little Q&A now. So please send your questions or anecdotes or anything you want to chat about into the chat box or the Q&A box. Looks like we don't have anything quite yet, so I will give it a few minutes for people to submit some stuff, and hopefully we get a few questions. Did get a comment from Holly. She said, incredible, thank you.
Oh, you're welcome, Holly. Be careful out there. Have fun.
Looks like we do have one question so far. Doug asks, how do I reduce my risk of arthritis?
Oh, excellent question. So first of all, there's different ways to get arthritis. So one way, based on this talk, you can get post-traumatic arthritis. So if you do get an injury, whether it's an ACL tear or a fracture or a recurrent dislocation of your shoulder, etc., you can get arthritis later because the cartilage, the white stuff on the chicken bone, can be damaged and then it can break down and then you get arthritis. So one way is don't get hurt. Other ways, a lot of people I see that get arthritis in the knees, some of it is genetic. You can't do anything about it. Some of it is age. We all get older. I mean, it's better to grow old than die young, right? So there's certain things we cannot prevent, but there's certain things that can help reduce our risk. So for instance, in knees, if you're overweight, that can put up to 6 to 8 times body weight onto your knees. So if you're 10 pounds overweight and you're starting to get some breakdown of your knee joint, lose the weight, because that 10 pounds can transmit like 80 pounds to the knee joint. So weight loss is good. Another important thing to help reduce progression of arthritis, or development for that matter, is good muscle balancing. So if you have good muscle strength around your joints, good flexibility around your joints, that's a great way. Certain sports can affect your risk of arthritis. For instance, if I have a patient coming in that, you know, has been a runner for 20 years and they've just really broken down their joints and they're developing arthritis, I recommend that you find a different sport. So if you do a non-weight bearing activity, cycling, cross-country skiing, water sports, etc., that's not going to put as much pressure on that already degenerating knee to progress it. Some patients of mine say, hell no, I'm never going to give up running. Well, that's fine, keep running, but you'll likely end up with a joint replacement sooner than before. Some people say, well, what if I take glucosamine and all these supplements? Is that going to prevent arthritis? Unfortunately, there's no evidence that it prevents arthritis. It can help the symptoms of arthritis, like pain and swelling in some people. But there is some pretty huge studies that were done that kind of didn't really pan that out, that it really can help arthritic pain that much. But having said that, I have plenty of patients who swear by it. And if you look in the veterinary literature, there's some studies that suggest that dogs and horses do better with their joint arthritis on the glucosamine. So you can try it if you like. I hope that answered your question.
All right, it looks like we got some questions pouring in now, so that's
Yay.
great. Next person asked, do you recommend wearing a knee brace 2 years after ACL surgery? And this person says that they're wearing a brace for skiing.
Excellent question. So after ACL surgery, I always tell my patients to wear a neoprene sleeve with skiing forever. The reason that is that neoprene sleeve can give you some form of proprioceptive feedback to your brain. So remember I mentioned proprioception earlier with the ankle sprains? What that means is there's these nerve fibers in the ligament in the ACL that when they're being stretched, it tells the brain to fire the muscles to protect the knee joint. Well, if you tear an ACL, that proprioception's gone. We can't put those back in the graft. But it appears that these neoprene sleeves, these compression sleeves that you can wear with skiing, can help restore some of that proprioceptive feedback. They're really cheap. They are very comfortable. So I always have people wear those. Now, the big knee braces, you know, those custom ACL braces, unfortunately, the literature has not supported those in reducing ACL re-injury. Now, if a patient says, I want one, I give it to them. Because if they re-injure their knee and they weren't wearing the brace, they'll blame me. But if you look in the literature, those big knee braces really don't work. And the reason is, if you look at the bones, okay, the ligaments holding the bones together, outside of the bones is your soft tissue sleeve, and the brace is outside of that. Well, if you get the right phantom foot mechanism, for instance, that I showed you earlier, you can still get that little twisting mechanism in there, even with the brace on, and still tear the ACL. I've seen plenty of people tear normal ACLs and ACL grafts in a brace. So I don't really recommend the expensive ones, but if you want one, it probably can't hurt. But the neoprene sleeves, I absolutely recommend for the proprioceptive feedback. I hope that answered your question.
Great. Really quick, because we did have one question about being able to tune in and watch this at a later date. To the person that asked that and to everybody else in the webinar, yes, this will be posted on our YouTube channel. So be sure to keep an eye on our website and our YouTube channel. All of our past webinars are on there. The last, I think, 2 are not uploaded yet, but they will be this week, and this one will be on here this week as well. All right, jumping right into the next question. What is the best exercise for ACL/knees for snowboarders?
Okay, so again, really important to have good balance between your quadriceps in the front of your thigh and the hamstring in the back of your thigh. That balance is important. Some people really work on their quads. They get these huge quads and their hamstrings are like, not so good. And that imbalance can increase your risk of ACL injury with all sports. It's also important to have really good hip flexors and hip abductors. Important to have good hamstring flexibility. So these are all ways to help reduce your risk. But sometimes you just get into a position where it happens. There's not much you can do. For the skiers, that phantom foot, they did lots of studies on those. And in some studies, it showed there was a 70% reduction in ACL injury when people did that phantom foot training, where they, looked at what I just showed you and kind of, there's videos you can watch. You can probably find them online, where it kind of teaches you how to recover during a fall to prevent ACL injury. In the snowboarders, they're pretty uncommon, but they can happen, like I said. But if you get that quadriceps and hamstring balance, I think that's the most important thing for you. And there's no ACL preventative brace that works. There just isn't. And if somebody knows of one, tell me about it. I would give it to everybody, including me.
All right, next question. I haven't skied into anything nor taken a fall, but one hip has a pain that comes and goes that started before ski season. Is it possibly dislocated just from walking?
No way. Not a hip. Hips, they have such, well, I can't say no way. If you had a dysplastic hip, meaning it was not formed properly, either as a baby or as you got older, I guess anything's possible. But for the average hip, it's a big ball and socket. So to be dislocated, no way. And you wouldn't be able to walk with a dislocated hip. But you could have something called a labral tear. You could have bursitis. You could have a tendon injury. There's lots of things in the hip that can cause pain. Or sometimes it can even be coming from your back. You could have a disc and people think they're having hip pain, but they're not. So if your pain is truly in the groin, yes, that's a hip pathology problem. Again, it could be a labral tear, a tendon injury, a bursitis, a cartilage injury. It could be early arthritis. I don't know how old you are, whoever asked the question. But if your pain is on the side, it could be coming from your back, or you could have bursitis on the side of your hip as well. So you might want to see your friendly orthopedist and try to figure it out.
Yeah, definitely. If you're experiencing pain and you want to enjoy your ski season, make an appointment with us. You can reach out via our website, one of our phone numbers, or you can just reply to the email you got this confirmation from, and somebody will be in touch with you. We're here to help you guys. So please don't hesitate to reach out.
Yes.
Next
and if
question.
you're in pain, don't ski. Figure out or snowboard. Figure out where the pain's coming from so you don't make it worse. Sorry if I interrupted you, Rachel.
Oh, you're okay. Yeah, no, that's a great point. Definitely. Be safe out there. Yeah. All right. Next question. Started off with thanks for the talk. I had ACL surgery this past summer. My question is, for the first season back skiing, 9 months post-op, are there any specific recommendations for reducing risk of re-injury to the surgical knee or the contralateral knee?
Absolutely. Make sure, first of all, your doctor clears you. You want to make sure, it's not just, oh, I'm 8 or 9 months out. You've got to be cleared by your doc and your physical therapist. So there's certain types of exercises and training situations that the therapist will put you through to make sure you're ready to return to snow safely. And sometimes you won't be quite ready to go all out and do extremes and jumps and everything else. But maybe you're just going to do greens and blues for the first couple months and kind of get your muscle memory back and get your strength back and really protect it. People who generally re-injure, unless it's a big traumatic fall and crash, are the people who did not complete their therapy. You got to complete it. You got to get back your strength, balance, proprioception, everything else back to where it was baseline before your injury. So that's super important. And as far as contralateral knee, I think if you have good strength and balance and you've passed all your physical therapist exams, the likelihood is low, but you know what? You tore your normal ACL the first time. A graft isn't better. It's almost as good as normal, but it's not better. So if you're in a high risk sport like skiing or basketball or volleyball, whatever you do, it's just part of the game. There's a risk of injuring the operated knee or the non-operated. So whichever, exercise regimen you can get from your therapist to maximize your strength and your balance and your proprioception is going to reduce your risk. But there's no way to completely eliminate the risk unless you just don't go skiing. And that's no fun.
Yeah. All right. This question, can you please talk about the best way to deal with patella pain that emerges the second year following successful knee replacement, where there has been excellent rehab and little pain for the first year following surgery?
Wait, can you repeat the beginning of that again? So they had a total knee and they're having patellofemoral pain. Is that what you were saying?
Yeah. So can you please talk about the best way to deal with patella pain? So second year following a successful knee replacement, where there has been really good rehab, little pain the first year following surgery, but it looks like they're experiencing some pain in their second year post-op.
Got it. First of all, you probably want to return to your surgeon, or if you don't have a surgeon around, Dr. Cafferty, my partner, just replaced my knee 10 weeks ago. I'm doing awesome. You probably want to see a specialist like that to evaluate and make sure that there's no loosening. Sometimes the implants can loosen. For instance, the little patellar button they put under the kneecap could loosen. Or it could be something as simple as, well, you did great the first year because you were doing all this PT. Maybe you're not doing as much now and your quad strength got poor, or you've got some imbalance in your muscles, which is making your kneecap not track as normally as it used to. Or maybe you just have a little tendonitis on your patellar tendon or your quad tendon, which is below and above that patella, respectively. So hard for me to just kind of generalize, give you recommendations on what to do. And particularly since you had a knee replacement, I think you need to have somebody look at you and see what the problem is, and then they can tell you what to do about it.
So couple comments from this, or it looks like we have some people asking about different topics. Dr. Beam, I think you're being demanded for some more future webinars.
Sweet, I would love to.
Yeah. So somebody asked us in another webinar, can you cover knee replacements? How do you know when it's needed and what is actually replaced?
Well, we just did a webinar on that. Dr. Cafferty, again, my partner, and I did a webinar just Rachel, a month ago?
Yeah, I think it was about a month ago.
It's available on our site, yeah?
Yep, that's available on our YouTube channel. So if you head to our website, you can find it there.
Yeah, it's an excellent webinar talking all about knee replacement. You should watch it. And hip too. Really excellent presentation that he did. So I would watch that for sure.
Awesome.
Yeah.
And then going off of just staying on topic of other topics, we have somebody who said would love to learn more about your thoughts on regenerative procedures, PRP, stem cells, etc. Maybe it's a topic for another talk, but what's good or bad with stem cells? I don't know if that is in any way you can relate to some of these ski and snowboard injuries, Dr. Beam, but I think that's a good topic.
It's a great topic. I could talk for a long time on that, so we don't have a ton of time at the moment. But what I can say is, at the moment, there is so much research that needs to be done before you just go out and get stem cells. There is not enough proof in the literature that stem cells is the magic cure for orthopedic injuries. And it's super expensive and it's invasive. So I am not a big stem cell fan at this time, although I do believe it is the future of medicine. We're just not there yet. And there's a lot of stem cell clinics out there that are just injecting everything, and there's not enough research to support it. And I don't think it's right. That's just my opinion. Maybe I'm going to make somebody mad out there, but that's just the truth. That's the way I feel about it. Now, I do a lot of PRP injections or platelet injections. That's where you take blood from the arm, you spin it down, you get this platelet-rich plasma, and you inject it into, for instance, an arthritic joint. There's a ton of literature that supports that. It can help reduce pain and swelling. It doesn't harm the joint like cortisone can. If you get too much cortisone in a joint, it can damage the joint, so I don't like it. It could also damage the rotator cuff if you get it in the shoulder region. But the PRP doesn't damage the joint, but it doesn't cure arthritis either. And it doesn't it doesn't prevent arthritis. All it can do is reduce pain and swelling from arthritis. In my opinion, in most studies say better than cortisone, better than hyaluronic acid injections with no harm to the knee. But they're expensive too. And the insurance companies just have not jumped onto the bandwagon here yet, unfortunately. I hope they will, because it helps so many patients. I personally used PRP in my knee for 3.5 years before I got my joint replacement. And it put that joint replacement off for me that long. I think they're great, but it doesn't cure the problem. You just have to be honest about it. And there's a lot of, stuff out there online, and you Google stem cells, you'll see all these clinics pop up, and they'll take your $8,000 or $10,000 happily to inject and regenerate your ACL. There's not one article in the peer-reviewed literature to show that a stem cell can recreate an ACL, put it in the right place, tension it properly, and avoid surgery. It just is impossible at this point. Someday we will have this technology, but it's not there yet. So stem cells, it's a pretty hard no, in my opinion, for most orthopedic injuries, particularly arthritis. PRP, I like for arthritis. I like it for some tendon injuries. I've had good success with those. And I hope that helps. But yeah, I could talk for a long time on that. And we do have one of our partners, Dr. Nurki, is kind of our regenerative medicine specialist. And has he done a webinar on this, Rachel?
He has, yes. So again, if you guys head to our YouTube channel,
you can listen to that.
Yeah.
Yeah.
We got I think we have a couple of them on regenerative medicine. There's also more information about what he does and his specialties on our website. So yeah, definitely go ahead there and check it out. All right. Next question. Are there braces for shoulders to wear after rotator cuff reattachment surgery?
Not really, no. No. So let your rotator cuff heal before you hit the mountain. I can recall, I'm not going to mention a name because he might be on here, but I did a rotator cuff repair on this gentleman. And I think it was 2 weeks later, I was out skiing with my family. And I remember I was bending down, fixing my boot. And in the corner of my eye, I saw this sling go by. And I look up and it was him in a sling skiing. And I had to ski really fast to catch up to it. And I finally caught him at the bottom. I said, "What are you doing?" He says, "Skiing." I said, "How did you injure?" Or I said, you're gonna fall and injure your shoulder." He says, "I never fall." I said, "How did you tear your rotator cuff?" "Well, I fell once." So yeah, there's no brace to protect that. You just have to listen to your doctor and your therapist, recover properly, and once it's healed enough, then go skiing or snowboarding. But there's no brace to prevent that injury that I'm aware of. But as I showed in the talk, there is a brace that can help reduce, not eliminate, reduce redislocation. So again, if I have a football player or a ski racer that just has to get through this season and they're very unstable, we can, try that brace. And if it keeps them from doing that, where they're going to dislocate again, that can be an advantage until they get fixed.
All right, next question. If you had a meniscus tear in surgery, can you re-injure it 10 years later without realizing it until you feel pain from the knee down to the ankle and even with possible sciatic pain?
Well, the meniscus is not going to cause sciatic pain generally. So if you're getting sciatic pain, which is pain that starts kind of at the buttock and then down the back of your leg and down the side of your calf, it could be you could have a disc problem or something in addition to your meniscus. If your meniscus surgery was a repair, they can re-tear. That happens, unfortunately, especially if you have another traumatic injury, or sometimes they just re-tear because they get degenerated. And you may not recall, any injury, but maybe you squatted down and pivoted while you're picking something up off the floor. And as you get older, that tissue degenerates. It's just not as strong as it used to be. And it can re-tear that way, even without trauma. So if you're having that much pain down the whole leg, that's not usually meniscus. Usually meniscus pain is right at the joint line. Sometimes you can get catching and locking or popping in that area. But as far as radiating pain down the leg, that's not as common. You may have something else going on. So you should probably see one of us to check it out.
Right. Next question. So I had a bad sprain. I'm in a boot for a week. Should I also wrap it? How will I know if I need an MRI?
Okay, sprain of what? Ankle? Does it say?
It
Or
doesn't
knee?
say. So to the individual who sent that in, if you wouldn't mind letting us
Yes.
know what the sprain was. I'm imagining it was like an ankle sprain or something. But let us know. For now, we're gonna move to the next question, I think, unless. So this individual raised his hand.
Right.
I have not, I'm gonna allow him to talk, Dr. Beam, if you're okay with that.
Please, yeah.
Okay. All right, Bruce, go ahead. If you want to share your story and ask your questions, feel free to do so. You
I
can
think he has
also
to
type in.
unmute.
Yeah, you are muted. If you're more comfortable, you don't have to speak on here. You can just type in your question, but wanted to give you the opportunity to talk to Dr. Beam directly. So I'm gonna ask you to unmute.
He's still muted.
Yeah. Still need you to unmute, Bruce. All right. One more second. All right, not sure. We're gonna get him.
Okay.
So Bruce, sorry, if you want to just message us and let us know or send into the chat. He just said it was an ankle sprain.
Oh, okay. So the ankle sprain, you know what? That's a loaded question because I don't know how severe your sprain was. It's very important that if somebody evaluates the stability of your joint after an ankle sprain, because it could be a very mild ankle sprain where you just need a little ankle stirrup or ankle brace, get into some PT. You could be back, back to sport in a week or two if it's super mild. But it could be more of a major sprain where your joint is actually a bit unstable. And in those cases, you might need to be in a more sturdy splint or boot. As far as advanced imaging like MRI, I rarely need to get an MRI on your average ankle sprain because those ligaments, if you get an MRI, it's going to show the ligaments are partially torn or sprained. We already knew that. They usually heal beautifully on their own with bracing and PT. So an MRI, which are very expensive studies, are not necessary. I usually reserve the MRIs for the ankle sprains that don't get better like they should. If they're not progressing in PT as they should, if they're still having issues, if they're having mechanical issues like catching or still gross instability after letting it heal for a while, then I'll get the MRI. Also, I alluded to that snowboarder's ankle where that talus fracture could be present. So if I suspect one of those, I get special x-rays and then sometimes I'll get a CAT scan for those. But advanced imaging is pretty uncommon for the ankle sprains, to be quite honest. I hope that answers your question.
He just sent in wrap also ?
Well, the wrap is part of that compression from the rest ice compression elevation. So a wrap is good to keep that compression on there to help reduce the swelling. So that's important. And again, depending on the severity, I'm sure your doctor made recommendations if they put you in a boot, whether to wrap or not. But if I have someone with a lot of swelling, the boot doesn't really give you as much compression as I'd like. So I'll put an ACE wrap on or a compression wrap and the boot, depending on the severity of the sprain.
Ski racers use body armor, should the rest of us?
Well, I hope the rest of us, like everyone on the mountain, doesn't ski that aggressive where they need body armor. People who go fast and are likely to crash, or more likely to crash than just your everyday run-of-the-mill skier, then yeah, I think body armor is probably a good idea. People who are in the trauma garden, they get so much air. I don't know that body armor really protects as much as people would like to think. But more protection is not a bad idea. But I think for the average skier, I don't wear body armor. But if you're, racing and you're racing down conditions which are extremely steep and slick and fast, yeah, you can crash and it might help you. I hope that answers your question.
So we have one individual who sent in a few questions, and they're pretty short, so I'm just going to rattle off them a couple at a time. So he has CBD cream on joints, question mark. So what's your opinion on that? And then are bumps and moguls just something to avoid as we get older?
Oh, those are good questions. CBD, you know, I'm an evidence-based medicine type of gal, and I don't have a lot of studies in the peer-reviewed literature that tells me that CBD works or should be used or shouldn't be used. So I kind of leave that up to my patients. Anecdotally, I have some patients who swear by it. They say, oh my gosh, it really helps my pain. I have other patients that say it doesn't do anything. I really can't recommend it until I get some peer-reviewed medical evidence that it's the right thing to do for my patients. So I'm not going to be able to answer that one. That's going to be just up to you. As far as bumps and moguls, as we get older and our joints are more vulnerable to injury, I would pick your bump days. So pick the bumps that are nice and soft and just, so, if you're a good bump skier, just beautifully nice and smooth, and you're not pounding and pounding on bulletproof days. I think you're going to preserve your joints for longer. If you have arthritis already in your hips or your knees, or for your ankles for that matter, you really want to avoid the huge bumps on the bulletproof days, unless you're just a spectacular skier like my husband. He can ski, but he doesn't even look like he's doing bumps. He goes down so beautifully, but and he's got some arthritis, but he doesn't notice it because he skis so well. But if you have arthritis, avoid the bulletproof days. Make sure you have good technique. And as we get older, yeah, you're more at risk of injury for the bumps for sure. I hope that answers your question.
Those are great answers. The same individual has two more questions.
Okay.
He asks, do you support hose type ski underwear? I'm not really sure what that question means, to be honest.
I think I know what they're talking about. Yeah, it can't hurt. It can, some people say it can enhance your circulation in your legs. It certainly can keep your muscles warm. They can be comfortable. Again, I don't have any medical literature. I haven't really looked at it lately to see if there's any medical literature to support or not support those, but I don't think there's any harm in it whatsoever. It might harm your wallet, but I don't think it'll harm you. And what's the last question?
I think you might say there's a little harm for this one, but it's a fun question, so I'm gonna read it anyway. There's a little alcohol at lunch recommended for all skiers. Or just
Did you say alcohol at lunch?
Just a little, he said.
Well, in my experience, the most common or the injuries that occur most commonly, oh my gosh, can you stand by 1 second?
Absolutely.
I have a, so what?
She's still won't go. She says anything covering is running her, and we don't know.
All right, I will make a split for her. Give me a few more minutes.
That's fine.
I'm on a webinar. Sorry, guys.
I didn't mean to
Just
interrupt,
if
but
she
I
wants
was
to wait, if she wants to wait, I'll be right there. Sorry.
Sorry.
Okay, so this is a fun question, the alcohol. I don't recommend it, honestly, and I'll tell you why. The most common time of day to get injuries, tibia fractures, knee injuries, etc., is right after lunch, after drinking some alcohol. So I can't say that I recommend that. No, that would be at your own discretion. And I hope you're over 21.
So to answer that question fully, no, it's not recommended for skiers, only for snowboarders. I'm just kidding.
No.
Don't go on the slopes, guys.
No, I didn't say that.
All right, we got one more question. Do you have any recommendations for whiplash from an injury sustained 9 months ago when my skis were abruptly trapped by an obstacle that fell across the lift line entrance? And do you recommend steroid shots? PT has only helped minimally.
I didn't hear your last sentence. Steroid shot what?
So, and do you recommend steroid shots probably for that? I don't know if in general or for that particular injury. PT has only helped minimally. So I'm going to assume it's for her particular injury, for just whiplash that she sustained skiing when her skis were trapped by an obstacle.
Understood. So honestly, there's no way I can answer that question without seeing the patient and the imaging studies. I couldn't even begin to tell you what to do for it until I had a specific diagnosis. Whiplash is not, that's not a good enough diagnosis to help me lead you to the right treatment options. So I would encourage you to go back to your orthopedic surgeon, and if that's who's been treating you, or if you haven't seen an orthopedic surgeon, see one, or a physiatrist like Dr. Nurki, or people who deal with spine. But yeah, that's, if you're still having trouble 9 months later, you should definitely be seen and evaluated properly to get a good treatment recommendation. Sorry, I can't help you with that one.
Okay, well, I think that's all the questions we have. If anybody has
Great.
any last minute questions, let us know, or you can shoot us an email. We did just get one more. Dr. Beam just got sent in. Do you want me to read that? All right.
Sure.
Any opinion on if wider skis are harder on your knees than a more traditional set of skis?
Did you say wider skis
Yes.
or what? Or wider?
Wider.
Like,
Yeah.
okay. Because I was going to say water skis. That's where you can hurt your hamstring.
Yeah, wider.
Yeah. So the wider skis, as far as carving ability, it's just a completely different way of skiing. Or are you talking about wider skis, like big powder skis?
I'm going to assume it's probably
Specify?
more of like the traditional powder skis you see a lot these days.
Yeah.
Yes, powder skis.
Honestly, I have not seen an increased risk of injury from the wider skis. However, I can say that if you're in deep powder, if you're a good skier and you're on the wider skis, you're less likely to crash. You're going to have a little bit more floatability and balance. But I have not seen a big distinction as far as types of injuries. Do you have more ACL injuries, more MCL injuries with the wider skis? I haven't seen any studies on that, and I don't have any anecdotal information based on my skiing population to comment on that either. I'm sorry, but I'd be happy to investigate and look in the literature for you if you like.
Awesome. Well, I think those are all of our questions. So again, if
Great.
anybody has more questions, please feel free to reach out to the email and ask any questions to the email you got this confirmation from. If you have more questions about Dr. Beam, please send those as well and check her out on our website. We didn't really get a chance, Dr. Beam, to talk about your background with, Olympic level athletes and collegiate level athletes and all that stuff, but you're very experienced, treating professional skiers and serving the US ski team and Team USA. So she knows what she's talking about, guys. If you want to come in and you want to get seen, definitely make an appointment. If you're not in the Gunnison area, we have other Team USA doctors over in Eagle and Summit. So we're here to help you this ski season. We want to keep you on the slopes. Visit us at alpineorthopedics.com or vsortho.com and fill out our appointment form if you want to reach out, or just shoot us an email. And keep an eye out for this webinar. It will be on our YouTube channel this week. And keep an eye out for more of these webinars. Please make sure you're signed up for our newsletter. And I hope everybody has a Merry Christmas.
Yes, happy holidays to everybody.
Yeah,
and
happy holidays to everyone.
Thank you for attending tonight. And hi, Mom. I see you're on there. Bye-bye. Take care.
All right. Thanks, everyone. Thanks, Dr. Beam. Have a great night. Happy holidays. Happy New Year.
Happy New Year. Bye.